Hi, friends. Welcome back from that quick break. For our next presentation, we are joined by Jeff Callard. Jeff is a physician's assistant in emergency medicine at Trinity Health Ann Arbor Hospital in Ann Arbor, Michigan. He's also co-director of the EPMG Envision Trinity Emergency Medicine Fellowship. Jeff's presentation on pediatric asthma will cover the objectives that you don't necessarily right now see on your screen, but that's okay.
Oh no, come
Uh,
on.
it's okay, no worries. Please help me in welcoming Jeff Callard.
All right, I shared it. Sorry, guys, it worked perfect yesterday. Let's see if it'll work better this way. Ah, can't have problems. We don't have time. Um, all right, share. It says I'm sharing, so unshare. Can you see it? Nope, can't see it. Can you see it now? Can you see it now?
I can see your
Yes.
presenter view.
Okay, well, I'll do that. Doesn't matter. That I don't have really many slides or anything hiding. I apologize. Let me see if I can get it. Use slideshow. All right. Well, that's that's blown up for me. Can you see my slides pretty easily or
We can,
oh,
yes.
everything blew up. Okay. So let's
Isn't that
start.
okay?
Again, my name is Jeff. Can you see everything clearly? Is it blown up?
It looks good.
Okay, thank you. So my name is Jeff again. I work emergency medicine for 36 years. I worked in a 2-bed ER. I worked in a 100-bed ER, and my ER is now expanding to 130 beds right now. So I have a lot of experience in different kind of situations. So one of the things near and dear to my heart is asthma. Oh, get that screen out of the way here. Just a second. All right. So asthma, having asthma, having my kids having asthma, and having one of my colleagues die of an asthma attack. While providers can get asthma and providers can die for it, even though they know a lot about it. So I think in a half an hour, we're going to try to get a lot of information in here to teach about this. And I think there's some cool things that I've learned from some of the research. So we're going to talk about the pathophys. We're going to talk about some of the treatments. I like to use cases for treatments. We're going to talk about some of the strategies for the crashing asthmatic, identifies some features and something you may not have used, some of the asthma scoring we'll talk about real quickly. And then one of the things we do in my community, I know some of you guys are super rural, some of you are more in a bigger communities. Something we use at our facility called our system in Ann Arbor, Michigan, which is a community paramedic, where I think that you can put a lot more of your skills to work to do some real good and cool things, okay? So I like to start with cases, and we're going to start with the cases. There'll be 4 of them. And then at the end, we're going to answer what we did. So first case, 3-year-old girl calls you guys with a cough, congestion, increased difficulty of breathing. You guys see these every day. My hospital's a level 1 trauma center, used to be a big peds referral center. Then the University of Michigan built the new hospital. So we've lost some of our people, but we still see, 50 kids a day, and depending on the weather and how busy the pediatric referral center is. So kids doesn't have a history of asthma, but been getting home treatments. You've seen this before. 2 treatments overnight seemed to help, but then they deteriorated. They are able to drink. These are all important things to know. Are they immunized? For me, that's super important. You may not care any asthma, but the interesting thing is, you may ask, why is she getting treatments? Well, her brother has asthma, but she has never been diagnosed with it. She's fushy, but consolable and alert. She has no fever and a respiratory rate in the 40s, some retractions, expiratory wheezing throughout the lungs, and her SAT is 94%. So we're going to talk about where do you go next with this in a little bit. I want to present these cases. Next is an 8-year-old. I did get rid of the fever to not make it complicated. Worse this morning, short of breath, using their inhaler, but only speaking in short sentences. And I want to, when you talk to us at the hospital, or you work at the hospital, maybe as a tech or something, or a paramedic at the hospital. One thing that helps me understand what you're dealing with is if you can tell me they're speaking in full sentences if they're 8 years old or even 5 years old, or they talk in 1 or 2 word sentences. That tells me a lot of how they're doing, more than maybe the pulse ox might, like they talked about earlier, more than other things. If you can tell me how they're talking and wheezing, that really is helpful. They've been getting albuterol, was recently inhaled. They're using inhaled corticosteroids, which are the daily medicine most asthmatics should be on. Albuterol, as you guys know, should be a rescue inhaler. And with their history of asthma, you have this red light flashing that they have an ICU admission in the past. So they're not using their medicine correctly. They're having an exacerbation. They're afebrile, tachypnic with subcostal, intercostal retractions. They're having both inspiratory, expiratory wheezing, and their SATs 90%. And if you guys are basics, God bless you. I worked in a basic service, and then we had intermediate, or they called our specialist. We still couldn't do a whole lot, but we at least had a couple meds with it. And then I worked in advanced as an EMT back in 1982. So third is getting a little older, 15-year-old with history of persistent asthma, presents via you guys again, respiratory distress, multiple asthma, multiple PICU admits, use vapes, but recently quit. And if he's like any other quit, when did you quit? Yesterday when I got sick. So you know how that goes. And then he's really bad, mom says, and that really should make the hairs on your neck go up. Also, tachypnic flaring, short sentences, 1 to 2 word, and cyanotic with a SAT of 85%. What meds do you use? What are you going to tell the hospital? And what's your asthma score, which we'll talk about in a minute. Now, the one you all just would love to see is you're at a soccer game with your kids, or you're on an airplane, or your grandkids, depending if you're my age. You see a kid on the field that seems to be struggling, a little dyspneic, a tachypnic, and retractions. And then there's the announcement, somebody saying, is there a provider? Is there an EMT or a doctor or PA or nurse in the house? And so you get down there, they have no history of asthma. So what are you going to do? You don't have any equipment, like basics have oxygen and maybe treatments in most places, but they can't do much. So what are you going to do on the airplane? What are you going to do on the field to help this kid? All right, well, let's talk a little bit about asthma. Asthma, 10% of adults and 30% of kids in the Western world have asthma. That's a lot of asthma. That's a lot of EMS calls. That's a lot of ER visits. 300 million people have asthma, and that's in the world, and 17 million in the US. 6 million under age 18 have asthma, and 250,000 people die in the US alone. That's a lot of deaths. That's a lot of EMS transports, and that's a lot of ED visits, okay? So what is asthma? Asthma is chronic reversible disease, okay? Not the COPD or smoker or exposures at work, but chronic disease of the airways, which can cause wheezing, breathlessness, chest tightness, and a lot of times one of the keys when we early diagnose it is nighttime or early morning coughing. Episodes are associated with widespread but variable airflow. So you may have somebody who has a little bit of wheezing. You may have somebody who's wheezing expiratory. Sometimes you'll have the inspiratory and expiratory wheezing. And then the worst one, the one you don't want to see when you're there, is the one with no wheezing that you can tell is really sick, okay? So, be prepared for all these. And again, this is what happens. The normal airways, the normal airways, so here on the right, you can see that they're open and wide. The bronchioles are open and wide. There's not a lot of junk in there. There's not debris in there. And then when we have an asthma attack, asthmatics are somewhere between normal and asthmatic airways. This is more like an asthma attack. You can see the amount of airway opening is decreased. So what happens? You get muscle contraction. You get vascular congestion. Those blood vessels dilate, so they kind of constrict down those lungs and the bronchioles and the alveoli, et cetera. You get bronchial wall edema. They get a little stiffer, and then they fill all that little bit you got open here with crap called mucus secretions. So now you have an airway that's it's blocked. It's not moving. And then what happens with that? So you get increased resistance because you have smaller airways, so there's more resistance. Your respiratory flow rate is decreased. You're not getting as much oxygen in there. Why we run into trouble with people with asthma when you have to intubate them because they have air trapping. So the air is going in, but it's not coming out because it's trapped on the way out too. So they can have airway ruptures. They can have a lot of other things. It's hard to get them off of a ventilator when you have to use them, which we're going to try to avoid here. And then the increased pressure causes a barotrauma, which can damage the alveoli. And then when you damage the alveoli, you can have bleeding, which can then affect your hemodynamics. So there's just a little bit of squeezing down with that mucus, et cetera, and that inflammation can cause lots of things. So one important thing, and these will go fast here, is everybody who's wheezing have asthma? We have adults. This is a pneumothorax. You can see anytime you see an EKG with arrows, or I'm sorry, chest x-ray with arrows, there's something wrong. This lung collapsed, okay? So they may wheeze with that. If you have pneumonia, you may see wheezing. If you guys took care of COVID patients, you may see a lot of wheezing. You may have epiglottitis, which is this little inflammation here, this what we call thumbprinting in the epiglottis. They may wheeze or have stridor, which is even more terrifying to us in the ED. So these people can all mimic asthma, as can congestive heart failure. Remember, all that wheezes is not asthma. Congestive heart failure, more than once I have seen with wheezing, and then pulmonary embolism too. All these things can cause congestive heart failure. Can cause an asthma attack, including a foreign body. Okay, so think about these things, but treat what you have with you. You don't have an X-ray. I can tell a heart failure and collapsed lung on an ultrasound quickly. Hopefully, I've talked about this every time I've talked to this group in Michigan. We get we get ultrasounds on the ambulance with some of our community paramedics so they can diagnose some of these things. But think about the things, the narrowing of the airway, the croup, the bronchitis, all can cause airway wheezing, which can then fool you into thinking they have asthma. But the bottom line is, when you're starting and with limited resources, you treat them like they're asthma, okay? The problem is, if you have an asthmatic, they may not be wheezing, which means they haven't started, or they're so tight that they're not moving enough air to cause wheezing. So consider how they're acting, how they're feeling. They're telling you it's asthma. It may be a little different to you, but I would start the treatment we're going to talk about shortly, okay? What might else you see? You'll see wheezing, yes, maybe, maybe no. You may see coughing. They will complain of chest tightness, not like a heart attack necessarily, but they don't know the difference. So keep this all in your mind too. They will be dyspneic, short of breath. They will have periods where they may feel better overall, and then they'll get sick again, okay? So these all are little things. So how do we decide asthma, and what are we starting to do now in the ED so we can quantify the asthma, which can help guide our treatment? Well, there's a pediatric severity scale, there's a pediatric scale, or pediatric asthma scale, there's PRAM and PI. All these are on a little free app called MD Calc if you want to use them. We just changed over the last couple weeks to PAS, pediatric asthma scale, okay? So these are the scoring, not the hockey scoring, but these are the scoring we use to help us. This is the one we originally used, and we will just go basically wheezing, how bad, workup breathing, how bad, and then prolonged expiration. We just moved to the pediatric score, which is a little bit better. And if you don't have a card somewhere that gives you normal vital signs for kids, that's an excellent thing to have. And most of your asthma educators or your asthma people who are the leaders in the ED can get you some of these for your ambulance. They'll give you ambulance to give you these scores. But basically we use, again, respiratory rate. We use breath sounds. Are they aerating good, fair, poor? Are they wheezing? And again, what I told you, are they talking in full sentences, partial sentence, single words? Are they wheezing? Are they really expiratory wheezing only? Are they inspiratory, expiratory wheezing, or are they not wheezing? Okay, again, I can tell the difference. I've been doing it a while, but I think you can too when they're struggling, not because they're just coughing and having shortness of breath, but you see they're struggling and you don't hear a darn thing in their chest. Those are the ones you really get worried about. Are they using their muscles? Look at their chest wall. They have maybe one site, a couple sites. They're using intercostal retractions, and they're SAT. Now, you guys all know SATs are not perfect in asthmatics or people with airway problems, but it's what you got. If you have end-tidal CO2, it's a little more accurate, but I don't have it on all my ambulances around, and we have all advanced ambulances in our county. So, pulse ox is the best we have. So if it's 95 and above, that's a 1, so we use that score. And then if you look at the bottom, the asthma score will kind of give you an idea what are they mild, are they moderate, are they severe? Hopefully you can just tell by looking at them, but this quantifies it. But it also, if you can give me a pass score or any of these scores, and then after you do some treatments and I see them, I see they've improved, or they started at 12, now they're 10, and then after treatment some more in the ED, they're down to 7. You've done a wonderful job. So let's talk about treatments. What do you have in a basic unit? You have oxygen. One thing to remember, it's not like COPDers, so you don't have to worry about stopping their CO2 drive. But remember, asthma may be important, but now the data shows if the pulse ox is not below 92, oxygen probably doesn't do anything to help. It may harm. I wouldn't worry too much about the harm in these younger people, but it doesn't really help. So we use 90 to 92 as our number for oxygen. Put them on a liter to get them up to 92. Put them on what you need to, okay? The mainstay of emergency treatment for asthma is going to be bronchodilators or beta agonists, okay? We have the word short-acting beta agonists because now they have long-acting beta agonists. We'll talk about those in a minute, but you don't need to know about those in emergencies because they increase morbidity and mortality, so we try to avoid the long-acting ones in an exacerbation. What's the short-acting beta agonist you have? Almost all you have is albuterol on most of our treatments. MDI, we'll talk about in a little more details in a minute, but MDI is the inhalers they use. You guys can use inhalers. We learned from COVID that inhalers can almost equal a nebulized treatment if you do it correct, and we'll talk about that in a minute. So nebulize 0.5, you put it in the little ampule and you shake it up, you put it on the oxygen, you give it to them. When they're sicker, I give them Q20 minutes back to back, or just put 15 milligrams in your little nebulizer thing and just run it constantly, okay? Just run it continuously. Remember, it's a beta 2. Remember, 2 is lungs, but it also has some beta 1 stimulation, which is your heart. So 1 heart, 2 lungs, if you remember the beta, it can cause tachycardia. What's the difference between an MDI and a nebulizer? Well, COVID taught us, because we didn't really think about this, COVID taught us that we didn't want to nebulize everybody because it sprayed all that garbage. We didn't know what was going on with COVID, all about people exposing other people. I certainly didn't want my nurses or my respiratory therapists to get sick from COVID. So we did a lot of MDIs, 4 to 8 puffs, 4 for a kid, 8 to, a kid size, an adult size kid is equal to an inhaler, pretty much. The main thing is you got to use a spacer, and we'll talk about a spacer in just a minute if you don't know what it is, okay? So inhaled long-acting, inhaled bronchodilators, long-acting ones, there's a few of them out there. Don't use them. Again, they have been found to cause increased morbidity and mortality. Stick to the short-acting ones. Stick to the albuterol. There was a drug that came out called Zopanex. It's a levo. It's like an L, if you guys know chemistry, which I took 100 years ago and don't remember much, but it's got an L isomer on it. It's supposed to be more beta 2 than beta 1, so a little less tachycardia. It's also supposed to be better for people who are quote unquote allergic to it. To albuterol, I'm still not seeing anybody truly allergic to it. The bottom line, though, is you can nebulize it, you can MDI it, but it is not in any way superior. It's very expensive, and most places don't have it. Most ERs, even big trauma centers, don't have it. We don't have it at any of the ones that I work at. I have 5 hospitals in my system in the Ann Arbor area. We do not use Zopanex. There will be a couple people that said that's the only thing they can use. We just don't have it. And it's not worth keeping on your ambulance because it's very expensive, and it really does. There's no superiority for it, okay? So inhalers. I told you it's very important. You can see where, if you look at sort of what we talked about at the beginning, what the situations are, okay, these are going to be something you could use. Inhaler spacers change everything. I used inhalers before there were spacers, like this little kid on the left. Um, Basically, you sprayed it in your mouth. You tried to get as much as you could get in there. You know, you see people around it trying to catch it all. Don't do that. Either make an inhaler by using some kind of a bottle or get a free one. I send every asthmatic home with or anybody I give an inhaler to, I send them home with an aero chamber or the one we have, the brand we have. There's some for kids. I've taught 2-year-olds how to use it properly with these little duck faces and these little things, and have not, they went from coming in every few weeks to not coming in back when I did a little bit more in a pediatric referral area in Flint, Michigan. So you can teach them to do it, and you can use this if you have it, okay? So what's the other drug we inhale? Well, ipotropamine or Atrovent, ipratropium bromide or Atrovent. Atrovent is a anticholinergic, which means it dries up. It also opens smooth muscle and bronchodilates. Generally, we find that, and the research has shown that you give the nebulized, I use Duo Nebs, maybe you've heard them, which is basically albuterol and Atrovent, mix them together, and I give 3 treatments, 20 minutes, every 20 minutes. After 3 treatments, most of the studies are showing that Atrovent or ipratropium really doesn't have an advantage, and the albuterol is more advantageous. So we stop at 3. I don't see any harm by doing more than 3, but that's just kind of how I was taught and what research I've heard, okay? What is the most important part of asthma, I think, is yes, the inhalers, that's what you can do. But I know more and more you guys are having steroids on your ambulance. And I can tell you that's a lifesaver for people too. The one we prefer now, being an asthma center and a treatment center for kids, is Decadron. The dosages I have in the back, I can't go through everything here, but milligrams per kilogram, anybody's welcome to my slides, and I have all the resources and the dosages and all that stuff on it. So don't get stuck on that. I'll be happy to share it and they're going to share some of them too. But give them what you got. Give them prednisone, 1 milligram to 2 milligrams per kilogram. Give them some Decadron. Why do we like Decadron over prednisone? Prednisone lasts from 24 to 36 hours. Decadron tends to last about 72 hours roughly, okay? The other question I can see already is, why don't we give it IV? There have been no studies that show IV is superior unless they barf it up, okay? So the action part of prednisone, Decadron, and Solumedrol, more the IV portion, is all the same. As long as they get it in their symptoms, you do not have to start an IV on an asthmatic, okay? Give them the oral if they can tolerate it. If they can't, then do the other. Earlier is better, because what I have found in our EMS system, which is, I think, really good, you guys will go through most of what I'm going to talk about, and they come to the ER, and I look at them and I say, well, should I just send them home, or do we need to admit them? Well, I know that their PAS score was low, or high, so I need to admit them. But you guys have done everything I can do. So if you have a good system, an ALS system, you can do these. But think about what you can do without those. So steroids are anti-inflammatories. They have some immune modulation as well. And their effect, we used to think, was hours. Now I've seen people that seem to turn around in a couple hours. So I'm not sure that's it. And again, PO versus IV, there is no difference unless they throw it up. Inhaled steroids are the mainstay of chronic treatment. I think there's going to become a time. There was a new study in GINA, which is an asthma consortium, global asthma initiative, and they're starting to use it. When I have exacerbations of my asthma, I use a steroid albuterol mix. And I did better than the oral steroids. It's not ready for prime time yet. You're not going to nebulize steroids yet, but I think you may in the very near future, okay? Well, what if you can't get the treatments? The treatments aren't working. What can you do then? Well, we can use parenteral beta agonists. What are those? Well, some of you may be old enough to remember terbutaline subcutaneous, but what else do you have in your rig most of the time, or some of these people have? Or if you're somewhere in an airplane, what could you use? You can use an EpiPen. EpiPen will help with the vasoconstriction. It will help, I'm sorry, yeah, the vasoconstriction. It will also help with the dilation of the lungs. So you'll have that. You can do drips and you can do epi drips, etc., but that's not something helpful. So epinephrine will help you with that. If you're in trouble, the treatments aren't working, you have a long transport, which I know some of you have in northern Michigan and other areas. We use nebulized epinephrine. Primatene Mist is MDI with epinephrine. I don't recommend it, but it can work in a pinch. Racemic epinephrine we use with croup, but we do nebulize epinephrine for reasons. You can give it sub-Q or IM, mostly IM now, and you can just use an EpiPen, an adult or a child-size EpiPen, but you use what you got. Again, be careful with IV Epi. We use it in arrests, and it can cause some cardiac disease if you don't use it properly. Just say be careful. The next step, I think, is if they're doing better but not better, the thing we're starting to use is magnesium sulfate. It's easy to give. It's super, super, super safe. You can give it over 20 minutes. You give 1 to 2 grams, even in kids. They just did a study recently that came out that it says it doesn't help everybody, but it benefits the sicker kids, and it decreases admissions in the ICU significantly. So that does have to be given IV. It doesn't work IM, but I used it just the other day and turned a guy around that I thought we were going to have to put in the ICU. So magnesium sulfate is a smooth muscle inhibitor. It helps it to dilate the lungs, okay? So what if they're not getting good oxygen? Some of you I know have CPAP or BiPAP in your ambulance. If they're starting to wear out, and again, this is not going to be for the inner city person who's 5 minutes from 10 hospitals. This is for somebody out in sort of the more rural areas. And so you may consider BiPAP because it may give them a rest. There's some PEEP to it, so they'll help push some air in there. It will work well. The advantage are it assists the work, it reduces their breathing, it gives them a little bit of rest, and it assists the alveoli so that they have a better gas exchange. This will help avoid intubation because intubation you try to avoid at all costs in an asthmatic because of the ventilator problems. Use it empirically. It doesn't matter if they're in failure. Heck, that'll work, even help them more. You want to coach them because it's not easy for people to use it. And the nice thing is you can continue to use your treatments in line, meaning you can get it through the machine, the BiPAP machine. We also some of you become comfortable with using high flow nasal cannula on your rigs, especially if you're doing transfers, but we used it in COVID a lot. It does do it at a higher flow, but it's warmed and humidified. And I had high flow nasal cannula put on by one of the reps, and for God's sake, the thing blew at top, cranked all the way up, and it was like using my CPAP at night. It didn't bother me. It's very comfortable. It doesn't give you the PEEP, the extra flow there, but it can help you in a pinch, okay? And it's a little better tolerated. We're going to hope we don't need to intubate, but let me tell you, if you're a paramedic and you do need to intubate, the drug you want to use is ketamine, because ketamine can be can be a bronchodilator, and it doesn't stop the respiratory drive. So they will continue to breathe even though you're sedating them, okay? And remember, if you do intubate them, make sure you don't overventilate them, okay? So back to our score. Let's get to our patients, okay? Well, again, I'm going to give this to you later. I'm going to just go through the cases using the PASS score. This is how we use it to determine treatments and admission, not necessarily something you're going to want to care about. What are the good things of asthma? Albuterol, ipotropamine, and steroids all decrease admissions. Magnesium decreases ICU admission, and high flow and non-invasive positive pressure ventilation BiPAP is promising in avoiding intubation, which is what you don't want. These are the doses. Again, I'm going to give these to you because I only have 20 minutes or 25 minutes here. So 3-year-old, remember, cold for a couple days, no fever, 2 treatments overnight, no history of asthma diagnosed, but there's undiagnosed. Drinking fluids, so that's a good sign. Immunized, that's a good sign. Fussy but consolable, that's a good sign. Respiratory rates in the 40s. They are retracting some. Only expiratory wheeze in the SAT is 94%. So by that, we know this is a mild exacerbation. We would use the albuterol and ipotropamine. We'd give them the Decadron or whatever steroid you have. This patient does not necessarily need O2. If they turn around pretty good, this patient might be able to go home. You got to make sure, from my perspective, I got to make sure they have refills of everything and they have a spacer. But this is a mild exacerbation that we might have turned around. You guys, this is one, they come in, you did all this stuff in the ambulance, and I can send them home right away. No, I'll watch them for a little bit, I promise. But we may be able to send them home because you saved them. Now we got the 18-year-old using multiple puffs of their albuterol metered dose inhaler, not talking in shorter sentences and shorter breath, history of asthma with ICU admissions, albuterol, but not using their chronic medicine, the inhaled corticosteroids, their afebrile, their tachypnic. There is intercostal and subcostal retraction, so that's two different areas. Inspiratory, expiratory wheezing, and speeding in short sentences. That's 90%. So we'll look here at our scores. So our pediatric asthma score is 10, which is moderate to severe. That's getting near severe. You're going to give your treatments of albuterol, ipotropamine, or Atrovent. You're going to get your steroids. This one, you're probably going to put on O2 and get them up to 92%. And you're going to hopefully be able to get some magnesium started. You may give them some epi sub-Q or IM as preferable. You've covered all these bases, which is what they recommend. This one is not going home with the shortness of breath, et cetera. So they're going to go either the ICU or the floor, depending on how well you made them before I got a chance to work with them, okay? The second to the last one is a 15-year-old with persistent asthma. You guys bring him in like all the other ones, multiple treatments over 24 hours. We're supposed to use our inhalers or our nebulizers no more than every 4 hours. Yes, we use it more, but if they're saying I'm using it more than, every 4 hours or 6 times a day, then you need to think that they're sicker. Ran out of their meds, so they used all their meds they should have for a month in 2 weeks. They used to vape, so that's not good. You're seeing terrible things from vaping, and have multiple admits for asthma and peds ICU units, but unfortunately not intubated yet. This kid's leaning forward and tripoding. You guys have seen that. You never like to see tripoding, okay? His respiratory rate's 28. His nose is flaring. He's retracting everywhere. He's speaking in 1 to 2 word sentences, and he's cyanotic. Nothing in there looks good to me, okay? So I need you to turn around before he gets there. So that's 85%. So you can guess that this guy, see this guy's kind of tripoding by leaning forward, blowing out, stuff's coming in, not coming out well. So this needs the duo-nebs times 3, and then you continue the albuterol alone every 15 minutes or continuously, however you want to do it. Give him the steroids. Decadron can be given IV, IM, or PO, or whatever you have. Put this guy on O2 until he gets up to 94, 92%. If you can't get him up, you want to use the BiPAP or high flow if you can. This guy is going to probably need mag and epi, especially in the ambulance, because you're limited, and get your intubation stuff ready. This kid is going to be in the Peds ICU unless you guys did miracles, which I have seen before, okay? So you get the sense there, the progression of how they get sicker. So now my favorite, what are you going to do when you're watching your kids or your grandkids, some other kid gets sick, they're dyspneic, they're tachypnic, they're retracting. The score would be a mild asthma attack, but they don't have a history of asthma. And is there a provider? Somebody knows something about medicine in the house? So first thing you do is get your people to call 911. Does anybody have an inhaler and a spacer? Please see if anybody has an EpiPen. You don't have to use it necessarily, but give them 4 to 8 puffs every 20 minutes like we do our breathing treatments. Give them 8 puffs. And if you ever get a chance, there's some nice videos on how to do the inhalers particularly, but the spacer helps a lot. Give them the EpiPen if they're not doing better, they're not turning around, and you'd be shocked how many people may have pulse oxes in their purses or in their backpacks, okay? So get what you can. Albuterol will do a lot of it sometimes. Hardly anybody will have steroids, so don't worry about that. But you have 2 things at your, there's almost always somebody with an EpiPen somewhere. So pearls, what things do I want you to remember? And I repeat things multiple times. Spacers are very helpful. Early steroids are very helpful. So in the ambulance, if you can give them, give them. Even if they seem to be super mild, give them steroids. Nobody will fault you. Vitals and studies may not be helpful. X-rays very few times help me. Pulse ox will lag behind, and so they'll get super sick, and their pulse ox will look fine until it doesn't. And one other question I didn't mention is ask an asthmatic how they feel. They may still sound wheezy, and you think, oh, they're pretty bad. Maybe we need to go to something else. They'll say, well, I feel better. And that's a little scary, but sometimes they can tell you more about themselves than you can see. Remember, CPAP and BiPAP will help you rest the lungs and get more air in there. Intubate when indicated, do it fast. Ketamine for induction, continuous treatments when indicated. Don't be afraid to just dump the albuterol in there, a couple doses, and run it. Magnesium will decrease the ICU admissions and help them feel better. And the steroids again and the EpiPen will help too on some occasions. And that's it. I think that was a quick course of asthma. I hope you learned something. We'll try to get some questions. I am happy to send this out. I have the scale and I have all these past how to do this. But I think that I covered the things in the EMS that I think you guys will find most helpful and interesting. And I'm going to stop sharing, hopefully, and go for the next person to get going. And I appreciate your time. And I appreciate you guys giving me some time to talk because this is something I'm really excited about. All right. So I'm going to try to get out of this without screwing it up. Am I out of it?
Yes, you are.
Okay.
Thank you, Jeff.
Thank you.
It's really hard to present a whole topic in 30 minutes. So we appreciate all of that and your resources. People are excited about your resources and looking forward to seeing those.
Awesome.
Okay, so for those of you who have questions, we're going to hold questions and then do a few questions at the end of Joan's presentation for both Jeff and Joan. So our next speaker is Dr. Joan Connell. Dr. Connell is an associate professor of community and family medicine and a clinical professor of pediatrics at the University of North Dakota School of Medicine in Bismarck. She's a medical director for the North Dakota Newborn Screening and Special Health Services programs, as well as serving as lead for North Dakota's EMS for Children Advisory Board. Welcome, Joan.
Thank you so much. Can everybody hear me okay?
Yes.
Sure
All
can.
right. Super. All right. Well, so as you can see, I'm going to talk about vaccine preventable diseases today. I have nothing to disclose, and I will share with you that the 95% of my material can be found in the article referenced right here. So feel free to use it. This article is comprehensive regarding 8 of the vaccine preventable diseases. And my slides are very comprehensive too, because I wanted you to have this as a resource that you could look back on. But obviously, given the constraints of time, we will only be touching on a few of the points in each of the slides. Our objectives are going to be to understand that declining immunization rates are going to result in reappearance of vaccine preventable diseases. And we'll look at prior herd immunization rates compared with current immunization rates. We'll review those 8 signs and symptoms of vaccine preventable diseases. And then we'll also talk about any treatment options and supportive care options that can be used. So, for those of you who don't know, this is the immunization table put out by the CDC this year. And as you can see, most immunizations are completed by kindergarten. So that becomes important in a few slides. This slide demonstrates how effectively vaccines are at eradicating disease. And if you look at the bar graph in red, you can see that that was the annual 20th century morbidity of each of those diseases in the United States. Then vaccines were invented and utilized well. And the yellow bars are the reported cases in 2023. And you can see anywhere from a 97% decrease in incidence of disease to 100% eradication of disease. This is another set of graphs that demonstrate that not only in the Americas, but throughout the world, vaccines have saved millions of lives. This is an important graph for those of you who are aware of the constraints at nursing, other resources, the expense of insurance, and the increase in the number of under and uninsured people. Because when you look at illnesses prevented, hospitalizations prevented, and deaths prevented from 1994 to 2023, those millions and millions of hospitalizations prevented, I think would be, if we completely stopped using vaccine, that would be unsustainable today with our constraints in our current healthcare. Unfortunately, as you know, most states have demonstrated decreased immunization rates across the board. And this slide looks at the decrease in kindergarten immunization rates since the pandemic. So if you look at the yellow vertical bar sort of in the middle of the slide, on the right-hand side is the pre-pandemic vaccination rates. And then to the left of that is the 2023 to 2024 vaccination rates. That top line is the US average, and then you can go ahead and find your state to see for the most part, the significant decrease in kindergarten vaccination rates. This is another graph that demonstrates that, and this highlights the herd immunity level at 95%, which is where the level of vaccination rate that protects people who are vaccinated, as well as those who are not vaccinated or can't respond to vaccine due to immunosuppression. And you can see that dramatic decrease in measles, polio, and whooping cough vaccination between 2019 and 20 to 2023-24. No surprise, you can see that this sub-threshold vaccination rate has already resulted in a surge of measles cases, which is what's demonstrated here. But we could look at other graphs that demonstrate increase in pertussis and other diseases. And just of note, the light blue bar parts are the US homegrown measles. This is not coming from outside countries. This is coming from within the United States. What's remarkable is if you look at these 800 cases documented in this graph from January 1st to April 17th of 2025 and compare that to the rate or the number of cases in the year 2023, 47, you can see that that is almost a 20 times increase in number of cases in a year. And we're not even, this is a third of a year. So next, I would like to go through those 8 diseases that are preventable by vaccines. And again, just hit the highlights that I think are most pertinent to you, but know that these resources are here for you at a later time. We'll start with Haemophilus influenza B, and that is a bacteria that can present with symptoms of serious bacterial illness. And the symptoms sort of vary depending upon where the bacteria is resting. What is notable about Haemophilus B is it's spread through respiratory droplets and direct contact with respiratory tract secretions. So I hope this, like others, reinforces your self-protection when you choose to don PPE. Very, very important for you first responders. Complications of Haemophilus B, again, depending upon where the bacteria lies. Pneumonia and meningitis, common complications, and all the sequelae that result from that. Excuse me. Epidemiology, because of those contact and respiratory spread, that's really important to use PPE. You want to be most worried about Haemophilus influenza in people who are unimmunized and those who are immunosuppressed. And I want to remind you that that includes people who have sickle cell disease because they're virtually asplenic, as well as Native Americans and Alaskan Natives. We do treat this with antibiotics, and you would be prophylaxed with antibiotics should you be exposed to one of these patients. This is one of the very unique diseases most commonly associated with Haemophilus B, and this is a radiograph of the neck demonstrating the thumbprint sign that can be seen with epiglottitis. And like Jeff was illustrating, the child who was tripoding and having a lot of distress, probably some stridor, that will be what this child looks like. With epiglottitis, if the child is maintaining his airway in any way, shape, or form, you do not want to stick a tongue depressor in. You do not want to intervene with the airway. Because they are extremely difficult to manage, and you really want to hope you can get to a higher level of care before the airway would need to be instrumented. Our next disease process is diphtheria, and this is a bacteria that releases a toxin, and it's spread through respiratory droplets and again, direct contact with secretions. So please don your PPE. It can look like a respiratory disease that presents like any other viral illness, mild fever, sore throat, difficulty swallowing. But then things get worse. You can get this significant lymphadenopathy, and we'll look at what that looks like. You can also get this pseudomembrane, and that's actually made of red and white blood cells, dead cells, as well as organisms that all mix into this disgusting milieu that we'll look at. You can also get diphtheria spots on your skin, and that looks like a scaly rash. Diphtheria can be complicated by the airway obstruction, particularly associated with the pseudomembrane. You can also get cardiac manifestations and neuropathy. Luckily for us, currently, US cases are rare, and management is primarily supportive as well as an antitoxin that can be used, and erythromycin or penicillin. If you look at the white in this illustration of this child's retropharynx, you can see that pseudomembrane. Now, if you were to brush along that with your tongue depressor, it would start bleeding profusely and further occlude the airway. This is that bull neck I was referencing. That is the consequence of significant lymphadenopathy, and this can also put some impingement on the airway. This is an example of the skin manifestation of diphtheria. So if you see this, be forewarned. The next vaccine preventable disease I'd like to talk about is tetanus, also known as lockjaw. So this too, the disease manifestations are a consequence of a neurotoxin produced by the bacteria Clostridium tetani. And what's important to know about that is this bacteria is a spore-forming bacteria that is ubiquitous in soil. So it's everywhere, and it invades someone because of a dirty wound, also sometimes because of poor cord care in the delivery of a baby. Signs and symptoms can range from localized symptoms at the site of wound, which can be localized muscle spasms. If the wound is on the head, you can have nerve palsies. The vast majority of patients present with generalized tetanus. And we will look at some of the illustrations of those manifestations, but typically symptoms begin with your masseter muscles, which are used for chewing, that get spasmed, and that results in this trismus or lockjaw appearance. Rhizus sardonicus is the grimacing look. We'll look at a picture of that. And that opisthotonus is the severe arching that can come with these horrible spasms. Neonatal tetanus is something that will usually manifest in the nursery, and these kids are miserable and then have overt spasms. So these spasms can be so bad, you can dislocate your jaw or have fractures of your jaw or other bones. You can have significant muscle breakdown that will look like renal failure. The case fatality without treatment is 100%. With treatment, it's up to 20%. Note that tetanus is more common in the warmer seasons when people are outside playing in the dirt. Management is supportive care, tetanus toxoids, cleaning and debriding the wound, so important, especially as a first responder, if you're able to manage any of that, giving antibiotics, and then most of these patients require ICU care. Here's that illustration of opisthotonus, and you can see this child is so arched, his back is arched up and he's rigid. This is this illustration of Rhizus sardonicus, which looks like he's gritting his teeth, but it's because his oral muscles are in spasm. This is that trismus or lockjaw where this baby can't open his mouth because he is in full spasm. The next topic I'd like to cover is pertussis. This is also caused by a gram-negative bacteria, Bordetella pertussis. It too is spread by respiratory droplets or direct contact with the droplet secretions. Signs and symptoms range depending upon what stage of the illness you're on. Usually no fever or low-grade fever in the catarrhal stage, which is when you have runny nose, cough, the symptoms of viral illness. But then it gets worse and you hit the paroxysmal phase where you have those horrible whooping coughs if you're a child or adult, and those sound like this. And you can't stop except to throw up. Note that if you're an infant, you don't have enough inspiratory volume to generate a whoop. So young infants have short staccato coughs that can't stop, and that sounds more like and I have actually seen a 9-month-old die on a ventilator of pertussis. So it is amazing at how debilitating this is. The paroxysmal phase can last for weeks, and that's followed by the convalescent stage where symptoms gradually wane over the next weeks to months. As I mentioned, pertussis is worst in infants, particularly those less than 6 months of age. A third of infants need to be hospitalized with this. Most contagious during that first catarrhal stage where they look like everybody else who has the common cold. Late summer to autumn peak. We do use antibiotics for treatment, and it's effective in reducing symptoms if antibiotics are started during that catarrhal phase. Only effective for decreasing spread if you start antibiotics after that. Note that this is one of those diseases that you as a responder would be able to obtain prophylactic antibiotics, and you would want to do that. This is an illustration of a child with that severe staccato cough. This cough is so severe in infants, but also in children and adults. It is common to have subconjunctival hemorrhages from coughing. The next disease state I would like to talk about is varicella or chickenpox and zoster. This is caused by a herpes virus called varicella zoster virus. Signs and symptoms, remember fever and kind of fatigue and malaise start before the rash, and then the rash breaks out. You are contagious 1 to 2 days prior to the rash till 1 to 2 days after the rash. So again, if you're transporting somebody or an early responder, you can be exposed before they have rash. The most common consequence of chickenpox is the secondary bacterial infection that is associated with that. And just prior to the invention of the varicella vaccine, we had several cases of severe secondary bacterial infection. In fact, I remember a 17-year-old who had necrotizing fasciitis as a complication of their chickenpox. You can also have pneumonia, heart problems, meningoencephalitis, liver problems, joint problems, and even kidney problems. Unfortunately, management is mainly supportive, but also requires isolation. And it's important to know that because if you happen to be exposed and you are not immune to varicella, you would get VZIG, which is varicella immune globulin, to help prevent disease spread to you. But your isolation would need to occur for 28 days after exposure. So a good reason to make sure that you are immune. Sometimes antivirals can be used, particularly if you're over 12 years old and unvaccinated or immunosuppressed. Sometimes VZIG is used in neonates. This is a classic varicella rash, and I want to illustrate that it looks like dewdrop on a rose petal. And you'll see a variety of lesions here, some bumps, some blisters, and some scabbed lesions. And they will all appear sort of simultaneously with on average 300 to 400 lesions, more if you're immunosuppressed. As I was alluding to, that secondary bacterial infection can be quite serious and is illustrated in this infant. Here's another closer up look at the various stages of lesions in varicella. Again, dewdrop on a rose petal. And then this last illustration depicts shingles in a child with leukemia. Remember, shingles can occur after a primary infection or even immunization against chickenpox. And that usually shows up in a dermatome, usually on one side, and a line is most severe in children who are immunosuppressed. The next vaccine preventable disease I'd like to cover is mumps. And this is also caused by an RNA virus, spread by droplet or salivary spread through close contact or contaminated surfaces. So remember to clean your rigs vigorously. It starts too with general symptoms of viral illness. But then you get your parotid gland swelling, which are glands in your cheeks, and that can last from 1 to 2 weeks. The swelling can be pretty significant and involve your neck. Unfortunately, one of the other complications of mumps is you can also get orchitis, which is inflammation of the testicles. So one of the complications of mumps is decreased sperm count. You can also get some meningeal manifestations, so hearing loss, trouble walking, kidney problems, heart problems, other endocrine problems. You are most likely to see mumps in late winter or spring. Management is purely symptomatic. This is an illustration of the parotitis or inflammation of the parotid gland, and you can see that most notably on the right in this child. This is a child who has right-sided parotitis and also significant swelling of their submandibular lymph glands. This is an illustration of mumps orchitis, noting that left swollen testicle. And this child, as I said, would be at risk for decreased sperm count and fertility. Next disease that's preventable by vaccines and well known to us this year in the United States is measles. So measles also caused by an RNA virus, airborne transmission, and extremely contagious. Initially, viral symptoms. We like to think of measles as the three C's: cough, coryza, which is tons of runny nose, and conjunctivitis. And that then is followed by a rash that starts at the head, moves to the feet, resolves from the feet towards the head. The red rash might evolve into sort of a copper color over time. And just prior to the onset of the rash, you can see what's called Koplik spots, which are white spots that you'll find on the inside of your cheeks and on the hard and soft palate. So measles can be complicated by pneumonia, by encephalitis. My aunt remembers having measles and had to be in her basement because she had such significant eye sensitivity for 9 months. 1 to 3 people per 1,000 cases die from measles. As I said, it's airborne spread, so extremely contagious. Unfortunately, the management is restricted to supportive care. Early this quarter with the Texas outbreak, we wanted to believe that vitamin A would fix everything, and it's certainly something that can be included in supportive care, but it is not curative. This is an example of the measles rash, and you can see compared to dewdrops on a rose petal, this is a more coalesced rash that's almost plaque-like. Sometimes it looks a little more hive-like. And these are those white spots on the buccal mucosa and on the soft palate that are illustrated here, called Koplik spots. The next is vaccine preventable disease I'd like to cover is rubella. And this is also caused by a virus, also very highly contagious. And you can get some complications as an adult who, or even an older child who gets rubella. I mean, there are some rare things that can happen. You can get arthritis. Once in a while, you get encephalitis or drop in your platelet count and consequential death due to hemorrhage. But the worst thing about rubella is what it does to the unborn fetus. If you are exposed to rubella as a fetus, particularly within the first 8 weeks of life, you will likely be aborted, 20% chance. If you survive, you will be at risk for congenital rubella syndrome, and this has a lot of manifestations, including hearing loss, cataracts, motor delay, heart disease, hematologic consequences from a drop in platelets, and we'll look at that blueberry muffin rash that's pathognomonic for rubella, diabetes and thyroid disease. And then the also unfortunate thing is you are contagious for 1 year. So that makes things difficult. Epidemiology is late winter and early spring. And unfortunately, there is no viral treatment for this disease either. It is primarily supportive care. This is an illustration of siblings with rubella. One closer up, and you can see that rash looks similar to measles. But this is a congenital rubella with that blueberry muffin rash. The last disease I would like to cover is polio. And polio is also caused by a virus. It is spread fecally orally and is highly contagious. Now, 70% of infections are asymptomatic. Others, you can range from mild symptoms, sore throat, fever, to severe. And by severe, I mean viral meningitis. And I also mean asymmetric flaccid paralysis. And this can be complicated by paralysis of the respiratory muscles, including the diaphragm and the intercostal muscles. It can also be complicated by a post-polio syndrome in 25 to 40% of the patients who had acute polio syndrome. Unfortunately, other complications include permanent paralysis, deformities, and we'll see an illustration of that, the respiratory failure that I alluded to, as well as cognitive impairment. Mortality rate of acute polio syndrome is up to 15%. Fortunately, right now in the United States, we have not had wild polio acquired here since 1979, the cases that have all been reported. And there was a cluster most recently earlier this year. But those are all a consequence of the oral polio vaccine, which is why if you look at that original vaccine schedule in slide 3, you will note that we only use injectable polio vaccine now, which is not made of the attenuated virus. It's made of little virus pieces. Management for polio, unfortunately, is supportive care, no approved antiviral agents. I wanted to show you this illustration of post-paralytic polio limb deformity. And I want you to know I had an uncle who had post-paralytic polio paresis and had to wear a brace from the age of 8 forward. This is an image of a child who is in an iron lung from their paralytic polio. And I want to remind you of this because of our limited resources that we have in healthcare right now, with limitations in nursing, in pediatric beds, etc. A recurrence of these diseases are going to result in more mortality than they would previously when we had better staffing and better access to care. So in summary, vaccines have been available and are very effective at preventing debilitating and potentially fatal diseases. Vaccines are safe. And I didn't go into that in this slide presentation tonight, but I can certainly provide you all the information you need for that. And unfortunately, given the declining immunization rates, we are seeing more vaccine preventable diseases, and it's important that we acquaint ourselves with them so we recognize how to best care for our patient as well as how to best care for ourselves. Thank you for this opportunity. I have a bunch of references at the end here, should you need them.
Thank you, Joan. We appreciate it very much. There are no questions in the Q&A. There are a few answered questions in there, particularly about asthma. If you're interested, you all can go in there and look. Right now, we will give one more reminder about EMS continuing education, because we do get questions all the time. It's a pretty big job to issue continuing education for 700 people. So we thank you for your patience. And again, it might take 3 or 4 weeks for us to get it all out there. Wanted to give you a reminder, as always, follow your own protocols, which are different in different states, depending on where you are and depending on your service or your hospital. Okay, quick break, sandwich break. If you can make a sandwich in 5 to 6 minutes, we will come back here promptly at 7:40 for our last presentation. Thanks so much.